Ma'am, we are live on YouTube. Should we start?
Yeah, I can start.
You ready? Yeah, just a minute.
Ready.
Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 15C, which is hematology erythrocytic disease. We are streaming live from Apollo Gleneagles Hospital, Kolkata. And a very interesting topic, which is aplastic anemia, acquired and inherited. And to talk on that, we have somebody who's an expert in hematology, a very experienced person. We have Dr. Colonel Atoshi Basu. She is an MBBS from AFMC Pune, MD Pathology from AFMC Pune, a senior consultant pathology at the famous Apollo Gleneagles Hospital Limited, Kolkata, with her areas of interest in hematology and lympho-reticular system. Dr. Basu has graduated and postgraduated from AFMC Pune with 30 years of experience as a pathologist in the Army Medical Corps, posted in mainly tertiary hospitals and worked in oncopathology and hemato-oncology in centers of the armed forces, histopathology and cytopathology posting predominantly in oncopathological centers. Currently, she is a senior consultant in Apollo Hospitals, Kolkata, and she is in hematology there with effect from 2017. She is a professor, erstwhile in the MCI and the National Board of Education, actively involved in postgraduate instruction and training, with areas of interest in hematology and lympho-reticular system. Before I ask Colonel Basu to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request, ma'am, please share your screen and let's start. Thank you very much. Right, ma'am, we can see your screen. Just make it full screen first. Yeah, and change the pointer. Yeah. Great. Please start. Thank you.
Okay. Good evening. And at the outset, I must express my thanks to Dr. Nadeem, who's given me an opportunity to participate in the Pursue set of lectures. I have been from time to time listening to this and attending the lectures, and I must say that we are going to make a wonderful set of lectures with lot of rich content. With that, I come to my topic for today, aplastic anemia. Inherited and acquired. I should not call it a topic actually, it's like a seminar. You know, I have a lot to cover, and well, if I miss out something, you will have to excuse me. Basically, there is bone marrow failure. And amongst the inherited bone marrow failure, all the names are very familiar, but I will be only dealing with Fanconi's, dyskeratosis congenita, Diamond-Blackfan and Schwartzman-Diamond syndrome, which more or less at some stage or the other present as an aplastic anemia. Of course, the list of acquired aplastic anemia is varied. Medication, chemicals, toxins, viral infections, PNH, and of course a large set is idiopathic or immune mediated. Definition. Obviously a heterogeneous group of disorders where pancytopenia is seen with a hypocellular bone marrow in the absence of an abnormal infiltrate or marrow fibrosis. Now please note, absence of an abnormal infiltrate or marrow fibrosis. So then what's the challenge? It's sounding simple enough, no? Patient comes with pancytopenia, you get a hypocellular marrow and it's done. But actually what practically happens is that there is a whole gamut of investigations which have to be done to come to the right logical conclusion. And why do we need to come to the right conclusion? Besides excluding other causes of pancytopenia, we have to exclude the inherited bone marrow failure syndromes, and should not rush into treating the acquired as the patient as a case of acquired aplastic anemia, because you see their toxicities, we'll come to that again later, the toxicities of the treatment of adult aplastic anemias is quite heavy on these children who have, or the younger generation which have inherited bone marrow failure syndromes. So then it is imperative that we screen for an underlying disease, and we have to religiously document any abnormal cytogenetics and PNH clones. Why? Because it affects prognosis and treatment. Okay, now the overlap. This is a photograph right out of Hofbrand, and the amount of overlap that you can see, you have aplastic anemia overlapping with hypoplastic MDS, PNH, large granular cell leukemias, then you have Fanconi's anemia, you have dyskeratosis congenita, you have the various ribosomal disease, and the list is quite extensive. So all this overlap which is there makes the diagnosis of aplastic anemia even more difficult. Now, what is the pathogenesis? Aplastic anemia, there is either a loss or a dysfunction of the hemopoietic stem cells. Now, it may be a quantitative loss or it may be a qualitative abnormality. It could be virus, radiation. There is the differentiation and self-renewal process is affected, and this makes them vulnerable to aplastic anemia. It is seen that FAS antigen on CD34 cells are increased in the setting of aplastic anemia, and FAS mediated apoptosis of CD34 progenitor cells leads to hemopoietic stem cell depletion. Now this is a busy photograph, lots of prongs here. The black ones are the ones which will inhibit proliferation, and the greens are the ones which will stimulate apoptosis. And look at the interplay. You have a stromal niche, you have the hemopoietic microenvironment, and you have this hemopoietic stem cell at the center. What is striking is the number of CD8 positive T cell expansion vis-a-vis some problems with the T4 helper cells. Also, the multipotent stem cell undergoes immune modulation, which decreases their proliferation. Vascular endothelial growth factor, microvessel density also play their role. Hence, it is multifactorial, aided apoptosis being aided by gamma interferon and tumor necrosis factor alpha. We will be referring to that through this pathogenesis time and again. Okay, now this is a little chart which sums it all up, sort of I can say a revision. High expression of FAS antigen, DNA damage. The bone marrow microenvironment is very important, because of which there is a reduced expression of osteonectin, which actually depresses the proliferation of the hemopoietic stem cells. CXCL12 secretion causes the tendency to differentiate into adipocytes instead of renewal of these hemopoietic stem cells. Aided with this is the deficiencies in immune suppression and gamma interferon release. Immune function, you just saw that NKT cells play an important part, and of course the genetic background, which we will be addressing in detail soon. There are mutations, and there would be structural problems in the chromosome such as reduced telomeres. So now some diseases have been sort of associated with acquired aplastic anemia, like thymoma, PNH, eosinophilic fasciitis, various autoimmune diseases. Now let us come to the diagnosis. Obviously, careful history is compulsory. Age at presentation, family history, drug exposure. This is a little older chart, but you can see the asterisk is always on chloramphenicol. Sort of, what should I say, epic work was done when chloramphenicol was implicated in causing aplastic anemias in a setting of usage of chloramphenicol. Infections, history of jaundice, occupational exposure, and of course SLE or other connective tissue diseases. Clinical examination: pallor, petechiae, icterus, hepatosplenomegaly, neck swellings, abnormal pigmentation. So what we have said, where the diseases associated with acquired aplastic anemia have to be seen and examined. Now let's come to laboratory investigations. Pancytopenia. Kamita et al. In 1975 first described the criteria by which we would define aplastic anemia: hemoglobin less than 10, platelet count less than 50,000, and ANC less than 1.5. Macrocytes and mild poikilocytosis. Sometimes in the early stages, isolated thrombocytopenia. I will be probably repeating this, but mostly in aplastic anemia, it is the thrombocytopenia which comes first. Though we call it aplastic anemia, but very often in the case of an evolving aplastic anemia, the first early stages will show you a thrombocytopenia. And you may have a presence of monocytopenia in the setting of a GATA2 mutation. Reticulocyte count, the next most important factor. Reticulocyte count less than 20 if you are counting manually, or less than 60 if you are assessing it by automated technologies. Bone marrow. Now bone marrow features are, especially bone marrow biopsy is the standard or is the primary investigation on which we base our diagnosis of aplastic anemia. Thereafter we go ahead and try to exclude the various causes. A dry tap is unusual. You do get, it may look acellular, but you do get fragments, and because they are consisting mainly of adipocytes, you feel that there is no particulate marrow. Fragments and trails, if you look carefully, will be hypocellular, and there is a marked reduction of hemopoietic cells. Sometimes if you see it on the low power, you may see that there are plenty of cells, but these are mainly lymphocytes, macrophages, plasma cells, mast cells, sometimes so prominent that at the first look you may say that there is no reduction of the marrow cellularity, but actually there would be a marked reduction of hemopoietic cells. Erythropoiesis is reduced or absent. Dyserythropoiesis is very common. It's in the form of either nuclear irregularity, cytoplasmic bridges, or binucleation. It is often marked, but it does not distinguish MDS from aplastic anemia. Means hypoplastic MDS and aplastic anemia is not decided by erythroid dysplasia. Megakaryocytes and granulocytic cells are markedly reduced or absent. Please note that dysplastic megakaryocytes and granulocytic cells, like hypolobated granulocytic cells, are not seen in aplastic anemia and is a very important pointer. Bone marrow biopsy, there are several caution to be given when we deal with a good, of course it has to be a good quality trifine biopsy of at least 2 centimeters. Avoid tangential biopsies. Through experience, I have seen that the subcortical marrow is normally quite hypocellular, and you may be mistaking biopsy as aplastic if you have gone tangentially and have taken mainly subcortical marrow. Please be careful. Now, bone marrow cellularity is age dependent, so it has to be sort of compared to the age of the patient. Hypocellular marrow, there is fat, there are adipocytes, and it is the myeloid cells which mainly get transformed into fat. So there will be a paucity of these myeloid cells. Instead, you will find lymphocytes, plasma cells, macrophages, mast cells, and you may also find lymphoid aggregates. Sometimes there is hemolymphophagocytosis. What is striking about the bone marrow biopsy is that the minute you see the biopsy, not only is it hypocellular, you will see what looks like a procedural hemorrhage. There is a lot of RBCs extravasated into the intertrabecular spaces. These are the walls of the sinusoids which are disrupted. Hot spots. I think enough cannot be said about these hot spots. These are around the sinusoids. These are patches of cellularity in an otherwise acellular marrow. So if you have done a aspirate, much to your bad luck, if you've taken an aspirate from one of these hot spots, your aspirate will look nice and cellular and will show a lot of erythroids. But it will be the biopsy which will be the clinching diagnosis. How do you make out this is a hot spot? Mostly the erythroids will be at the same stage of development. Please notice next time you get a bone marrow biopsy from a aplastic anemia with hot spot, please see that around the sinusoids the RBC is extravasate, and also there mostly you see collections of erythroid cells with and surprisingly they will be at the same stage of development. And of course I told you already it's a megakaryocytes which are first to be affected. Sorry. Okay, this is a photograph of a hypocellular marrow, lots of fat, and here also you can make out that, and you will see that, I don't know whether you can make out, but there is just one little meg there, and there isn't any other cellular or residual hematopoiesis. Mostly these are lymphocytes and plasma cells. I took out some more smears which show plasma cells very clearly. What else to look for? Please look for blasts. It could be a hypoplastic MDS. Please look for any abnormal cell infiltration. Look for fibrosis. Your diagnosis and your approach will change. Look for granulomas. Lymphoid aggregates, of course, can be found in aplastic anemia as well. Dysplasia, sometimes it would be useful in the presence of micromegakaryocytes to do a CD61 to exclude dysplastic micromegakaryocytes, which are I would not say hallmark, but are prominently seen in the setting of a MDS. Okay, now I thought let me bring this slide up here only and finish off a very large topic, aplastic anemia versus hypoplastic MDS. Obviously, I am not going to be doing justice to hypoplastic MDS. Bone marrow cellularity less than 10% cellularity. Cellularity actually can be either way, but erythropoiesis in nest called hotspots. Myelopoiesis will be present, and megakaryocytes will also be present, but they will be dysplastic. All three lineages may show possible dysplasia, whereas in aplastic anemia, it's only the erythroid series which will show you dysplasia. CD34 and 117, you may get variable results depending on what stage of MDS you are seeing. Marrow fibrosis. Yeah, marrow fibrosis is seen, is possible with MDS, but absent, absolutely absent, as we defined in the as we said, the definition was absence of fibrosis. PNH clone, we'll come to that later. And splenomegaly, traditionally in your MBBS you're taught anemia without splenomegaly. You know, one of the important causes is aplastic anemia. The original Kamita criteria, here, this is a system which is being used since 1975, modified later by several other people, and you have marrow cellularity less than 25% and at least 2 of absolute neutrophil count less than 0.5, platelets less than 20,000 and corrected reticulocyte less than 1. The current which we are using now when we report the marrow or the case in entirety is that marrow cellularity remains less than 25% or less than 30% of residual hematopoietic cells. But what has been brought down, neutrophils are 0.5 and platelets are also less than 20,000, but here the reticulocyte count has been brought in. Very severe is if the neutrophil count is less than 0.2. Absolute neutrophil count is less than 0.2 and non-severe is anywhere between these two. It is important to know this because time and again the severity has to be assessed at the laboratory level. Further investigations, of course, LFT. Please note that LFT may be done, but viral studies in hepatitis are usually negative. You may have to do HIV, CMV and Parvo B19, anti-nuclear antibodies, vitamin B12 and folate, and of course HbF percentage, which we will again come back to when we do the inherited bone marrow failure syndromes. Word about hepatitis associated aplastic anemia. Seronegative. Please note seronegative hepatitis, and the cytopenias have set in after the hepatitis resolves, and presently the treatment is hematopoietic stem cell transplant, ATG and cyclosporine, but actually the fatality rate is very severe if it goes untreated, and about 30% of the patients receive a liver transplant. Okay, little bit about treatment. Allogenic sibling matched hematopoietic stem cell transplant or immunosuppressive therapy with ATG and cyclosporine till you find when there is no sibling donor, or you are in the this is the first line. If there is no sibling donor, salvage therapy for response failure in 3 to 6 months. Unrelated donor hematopoietic stem cell transplant is picking up now, and the results are quite encouraging. With that, I am closing the chapter of acquired aplastic anemia and going on to the inherited bone marrow failure syndromes, which will come as aplastic anemia. I hope at least the basics of interpreting bone marrow aspirate and biopsy and the peripheral smear with the reticulocyte count will stay with you. Now, besides the fact that inherited bone marrow failure syndromes is one of the exam questions which are asked to postgraduate students, why so much of fuss? Why worry? These are not as rare as previously believed, and this has been helped out by cytogenetics, and the better techniques, better molecular techniques have shown us that these are not as rare as we had believed previously. They are under recognized de novo, and actually by the time they present, they may be presenting as aplastic anemia or even worse, malignancy. It has implications for treatment. Conventional treatments which are used may cause excess toxicities in these cases. They require different treatment protocol, and the donor selection, especially if you are going to take a sibling or a donor, will be a problem if you do not screen the donor for inherited bone marrow failure syndrome, and implications obviously for family planning. The first of the lot is always Fanconi's anemia, a DNA fragility chromosomal breakage disorder. The acronym VACTERL, vertebral, anal, cardiac malformation, teophistulas, atresias, limb defects are all known in association with Fanconi's anemia. Of course, please note 30% will lack these physical anomalies. And the physical anomalies, as we can see, the most important are short stature, cafe au lait spots, thumb and radii anomalies. Yeah, so we have these. This is a well-known cafe au lait spots and problems with the digits. These are well-known anomalies associated with Fanconi's anemia. But as already said, 30% may not have it. Now let's look at the genetics. It could not have been more. There are 22 distinct genes, and Fanconi's anemia A, C, G, D1, D2 up to V have varying kind of presentation, varying kind of penetrance, causing varying kind of severity. The Fanconi anemia proteins constitute a nuclear protein complex and are involved in DNA repair pathways in response to genotoxic insults. Of course, currently there is evidence that in stress signaling and apoptosis, in response to oxidative damage and inflammatory cytokines, these FA proteins may also have some role. I've tried to make it a little simpler, though it's looking quite complicated already. The Ashkenazi and the Afrikaans are there everywhere, and 1 in 100. Most common is Fanconi A, followed by Fanconi C. Fanconi A thankfully has a later onset of bone marrow failure. Most of them are autosomal recessive except Fanconi's B, which is X-linked. We'll come to Fanconi's V and D1, and you obviously need a mutational analysis to arrive at a definitive diagnosis. C and G have a more severe course. Important to know that Fanconi's D1 is synonymous with BRCA2, and these have very early onset MDS and AML. Fanconi's C and D1 on N will have Wilms tumor or medulloblastoma. So all in all, whichever there is a need for a mutational analysis or complementational studies to establish the correct diagnosis not only of Fanconi's anemia but also of the subtype by doing your gene analysis. Hematological findings of pancytopenia. Fetal hemoglobin is elevated for age, and this has a role in subsequently in the prognosis of the case. There is hypocellularity with decreased number of hematopoietic precursors with normal morphology. Stress erythropoiesis may be seen in the pre-anemic and anemic or patients in remission. And you may even you may see even erythroid hyperplasia. Now let us look at the clinical course. 7 years median age at diagnosis. Aplastic anemia by 10 years will be manifest, and at 20 years the patient may come down with MDS or AML. Please note that between 20 and 40 we have MDS and AML, 40 onwards we have solid tumors. So the patients who go undiagnosed because of the fact that they do not have any outward developmental anomalies are likely to, and you are likely to miss their diagnosis. They should be suspected when young individuals come with MDS or will MDS going into AML. In Fanconi anemia patients, maybe because of the extensive chromosomal breakage, when they present with AML, the prognosis normally of a younger person presenting with AML is better than an older person, but unfortunately in the setting of Fanconi's anemia that is not the case. They have reciprocal translocations which are associated with older individuals, not with the younger patients who have a favorable reciprocal translocations. In fact, they have multiple chromosomal deletions and additions which are more typical of MDS, AML seen in older individuals or those with therapy-related leukemias. These include unbalanced gains in the long arms of chromosome 1 and 3, deletion of chromosome 7, we'll talk about chromosome monosomy 7 again, and of course RUNX1 somatic mutations are seen in 20% of the patients with Fanconi's anemia and AML and are both associated with a poor survival. Diagnosis, we are doing, of course, we are doing a functional stress testing by using diepoxybutane or mitomycin C, which are carcinogenic agents, and they induce DNA cross-linking or DNA breakage. So lymphocytes are isolated, stimulated with phytohemagglutinin and mixed with either diepoxybutane or mitomycin C. How do you compare it? We compare it with the normal control. In addition, genetic testing by mutation analysis and sequencing and complementation test. Yeah, what are the results that you can get? This is a result from a patient with Fanconi's. You can get gaps, you can get breaks, you can get triradial, quadriradial forms during which will be observed. This is we are doing karyotype by metaphase. Malignancy in Fanconi's anemia. Risk of malignancy is 1000 times greater, and by adulthood 30% will develop malignancy. Clonal abnormalities will be present in as high as about 50% of the patients. 10% get leukemia, AML being more common, especially M4, M5. 10% get solid tumors of the squamous cell carcinoma of the head and neck, and a small number will get adenomas or hepatomas or tumors of the female genital tract. The pity or the problem is that this risk is increased by hematopoietic stem cell transplant. So you are caught between the two devils. Secondary squamous cell carcinoma places you at a 4 times greater risk after getting a successful BMT done. There is a shift in the age of the solid tumors. These come 16 years earlier, and the solid tumor risk is associated with inflammation of GVHD. Therapeutic options, of course, transfusion, management of the congenital anomalies, growth factors, danazol, but as yet we do not immunosuppressive therapy. We do not have much to offer other than hematopoietic stem cell transplant. Unfortunately, even doing a hematopoietic stem cell transplant not only does not obviate the risk of a malignancy, in fact it makes them 4 times more susceptible. With this I come to another set of disorders. Telomeropathies. I will not be discussing all the telomeropathies. We will just be touching upon a little bit about telomeres, and a dyskeratosis congenita is what I am going to be discussing. Now this is a normal telomerase complex, the sets of 6. There are the telomeres are made up of set of 6 amino acids, and you may have germline telomere disease like we see in dyskeratosis congenita, or there may be an abnormality in the TERT or the TERC gene, NOP10, and a whole which causes a telomere loss. It may be regenerative stress, that is, it is implicated now in neoplasia, and there may be DNS damage brought about by the gamma radiation, toxins, or inflammations. Now, ectodermal dysplasia is a DNA repair defect. The triad is of a reticulated skin, hyperpigmentation, leukoplakia, dystrophic nails. So, leukoplakia, dystrophic legs, hyperpigmentation, and reticulated skin. Aplastic anemia develops in 50%. And again, solid organ cancers and leukemia occur at an early age of 3rd to 4th decades. Characteristically, these children come down with AML, and the carcinoma is of the bronchus, tongue, larynx, esophagus, pancreas, and skin. Now, let's look at the genetics of this. Telomeres are specialized proteins, DNA and DNA complexes at the end of chromosomes. They stabilize the chromosome ends, which prevent premature shortening, translocation, breaks. So they are the ones which prevent the ends from becoming sticky and hence they are the ones which do not allow loss of the chromosome due to abnormal shortening. Now the hallmark of this group of diseases is that the telomeres are very short, less than third percentile. And all the genes that we have mentioned are in the telomerase complex at both ends of the telomere. Yeah, all these genes are impaired time and again. This is the telomerase complex. And there are three patterns of inheritance: autosomal dominant, recessive, and X-linked. Now, diagnosis does not need the classical triad or the physical stigmata. Very short telomeres are seen less than 1/1 percentile for age in more than 3 lymphocyte subsets, and negative genetic testing may not rule out the diagnosis. So this is a difficult condition which is associated with organ failure. You may get an acquired aplastic anemia if there is a TERT or a TERC mutation, but these are milder. Lung fibrosis, cirrhosis, esophageal and lacrimal duct stenosis, enterocolitis, immunodeficiency, and avascular necrosis have been described. In fact, if the genetic testing is negative and the patient comes to you with lung fibrosis and cirrhosis, please suspect a telomeropathy, especially dyskeratosis congenita. Okay, now we come to the third entity. Does not actually, anemia is what has been said, and anemia is that which happens, but there will always be a fleeting neutropenia and a thrombocytopenia. 47 of all patients present with 50% have tau colored hair, blue sclera, and glaucoma. Now, upper extremity shortness, short stature, small bony abnormalities very often get overlooked. Neutropenia and rarely thrombocytopenia may also develop. Diagnostic criteria: age less than 1 year, macrocytic anemia, reticulocytopenia, and a paucity of erythroid precursors in the marrow. Supportive criteria are the major criteria, which are the pathogenic mutations, positive family history, elevation of red cell ADA. This is an important marker, congenital anomalies, elevated HbF, and no other bone marrow failure syndrome, because we have said that you do not require, it may not present in a classic form. These are ribosomal protein mutations and deletions. So these are ribosomopathies. They may be sporadic, usually autosomal dominant. And the one in which we get diamond blackfan anemia is RSP19. There are a whole deal more which are there. The ribosome, they assemble proteins from amino acid, which is what is affected in and causes defective erythropoiesis from haploinsufficiency. Now, one of the ribosomopathies in which the mutated RPS14 is there is associated with 5q deletions and is a marker for MDS. What is the outcome? There is solid tumor risk remains, but some of them have a remission 20% by 25 years of age, and there may be no predictive genetic or clinical features. Hemopoietic stem cell transplant is only done for transfusion dependent patients, particularly those who are immunized or have neutropenia. Now, sibling donors have to be very carefully evaluated, because as you have seen, there may be remission and there may be no predictive genetic or clinical features. A word about Pearson syndrome, I just brought it up because of the fact that it's a sideroblastic anemia seen in young children with a pancreatic dysfunction, and there are vacuolated precursors. What we are more interested is in the other entity, which sometimes we are not discussing this entity at all, transient erythroblastopenia of childhood. Why brought this out? Because it may be a child who has not been diagnosed to have a hemolytic anemia and has an acquired aplastic crisis, which has been usually in which Parvo B19, which we have said is a cause of an acquired aplastic anemia, and HHV6 may be implicated. So you may mistake it for a Diamond-Blackfan anemia. In this case, of course, the count improves as the infection is tackled. The other condition that we will be discussing is Shwachman-Diamond syndrome, pancreatic insufficiency. 100% of the patients will have delayed bone maturation and short stature with metaphyseal dysplasia. How does it present? Actually, the presentation is more to do with transaminitis and pancreatic isoamylase, fecal elastase estimations are done. Metaphyseal chondroplasia is quite common, and there may be short stature with cardiac and endocrine development issues. But what we see in the setting of an aplastic anemia is a fluctuating neutropenia, because it's supposed to be an impaired chemotaxis. Anemia and thrombocytopenia is seen in a small number, that is 20%. Aplasia means classical aplasia of the bone marrow may be seen in maximum 25%, and they do progress to MDS and AML. Again, there is a mutation in the SBDS gene, which is the ribosome dysgenesis, and hence the SBDS gene, which is at the 7th centromere, or there is an adjacent pseudogene. These are the two which promote the ribosome joining and mitotic spindle stabilization. Hence, the anomalies which occur because of Shwachman-Diamond syndrome are because of the ribosome biogenesis is affected. So with that we come to, that is as much as I am discussing the inherited bone marrow failure syndromes. I think we've covered most of them, which will present as aplastic anemia. The rest of it usually has isolated cytopenias and does not actually go into an aplastic kind of a picture. But more important is to diagnose. Let us see what all we can do to diagnose these inherited bone marrow failure syndromes. Of course, characteristic physical anomalies will make our job easier. Unexplained macrocytosis with or without characteristic birth defects. Children with aplastic anemia or myelodysplasia. Patients with malignancy who are sensitive toxicity. Unexplained toxicity to chemotherapy and radiation. Head and neck or esophageal cancer less than 40 years, vulval cancer less than 30 years, and what could be more of a red flag than the fact that the family members are affected. Diagnostic approach, besides the normal investigations, or besides the basic investigations which have already been discussed, at this stage we will lay some emphasis to stress cytogenetics, which I have actually covered when I have spoken of the mitomycin C and DEB testing. We will see what is the implication of clonal hematopoiesis in aplastic anemia, which makes cytogenetics and the study of somatic mutations so important. And of course, no presentation on aplastic anemia can be done without mentioning the PNH clone and of course your telomere length analysis. Clonal hematopoiesis in aplastic anemia. Now, in aplastic anemia, this is metaphase cytogenetics, there is a numerical expansion of clonal cells. Clonal cells will predominate with typical chromosomal aberrations, and a diagnosis of a clonal malignancy is possible in that case. But in aplastic anemia, these clonal abnormalities may be transient and they may be present in a proportion of metaphases only, and pseudoclonality is because of the stem cell depletion. With this slide, actually I am making a bid to say that maybe metaphase cytogenetics is not good enough in cases of aplastic anemia. Paroxysmal nocturnal hemoglobinuria, acquired clonal stem cell disorder with mutations in the PIG-A gene. This gene functions in the GPI anchor biosynthesis. We all know that because there is it stabilizes the cell membrane, there is a problem when leaving the cells at risk for complement mediated lysis. CD59 and CD55, which we were estimating or at least trying to do a qualitative test or a quantitative test, haven't stood the test, are present on erythrocytes, and we were initially diagnosing based on CD55 and CD59 expressed on the RBCs. PNH leads to hemolysis, hemoglobinuria and thrombosis, venous or mesenteric. Diagnosis, well, not the forum to discuss diagnosis of PNH, but yes, 55-59 were given up, as was HAMS and sucrose lysis, because CD55 and CD59 was expressed on RBCs. Now, obviously PNH in the setting of aplastic anemia would be having, or in the setting of hemolysis and hemoglobinuria would require transfusions. So there were a great deal of false negative results. Presently, the gold standard is flow cytometry with FLAIR, CD157, CD24 and CD14. These CD24 and 157 are your granulocytic markers along with aerolysin, which is fluorescent tagged, and CD14 is a monocytic marker. Aplastic anemia with a PNH clone. We've heard this terminology often. It can occur before or even after therapy. In fact, 50% of all aplastic anemia patients, thanks to sensitive flow cytometry nowadays, will have small PNH clones. The marrow is hypocellular, and somehow severe cytopenias in PNH positive patients may respond to immunosuppression. Somehow there is a strong selective advantage of these mutated cells, meaning immunosuppressive therapy in PNH positive aplastic anemias do better than if the patient did not have a PNH clone. The only problem now, we have selective advantage, hence the other problem is a risk. The larger PNH clones, which are expressed as percentage GPI deficient, may cause hemolysis and may cause thrombosis. Hemolysis may be due to the nitric oxide depletion and platelet activation and the free hemoglobin, or the GPI deficiency may cause a lack of tissue factor inhibitors and decreased fibrinolysis. Immunosuppressive therapy is very good in the setting of PNH with a small clone, but the clone size may increase or a measurable clone may develop after immunosuppressive therapy, which usually, thankfully, is usually stable but can also progress. So immunosuppressive therapy in the setting of PNH clones in aplastic anemia has to be very has to be very cautiously given. So how many times to screen, when to screen? When you diagnose an aplastic anemia, please screen. You may continue to screen for 6 months, say 3 times in 6 months. If it comes negative, then maybe you can make it yearly or even 2 yearly. So again, to reiterate my point, clinical significance of PNH clone. PNH clone in aplastic anemia predicts a better response to immunosuppressive therapy. But significant PNH clone, which is more than 50% size of the clone, receiving ATG should be actively monitored for signs of hemolysis. 10 to 15% may develop PNH clones after treatment, but as I told you, most of them remain stable and do not show hemolysis or thrombosis. Now the other tricky question. Whenever there is clonality, we cannot leave MDS far behind. So clonality is a long-standing issue, and clonality has been revolutionized using sequencing technologies. Obviously, I cannot be going into the details of the sequencing or cytogenetics, but I will attempt to at least introduce the subject. Now, conventional cytogenetics, that is what most of us had right now. When there is a hemato-oncology center, they do have, they may be having SNP karyotyping or next-gen sequencing, but most of the centers will start with conventional cytogenetics. Now, the problem here is in obtaining sufficient number of metaphases. You need at least 20 analyzable metaphases. More than 2 cells having the same structural chromosome rearrangement or an extra chromosome, or more than 3 cells with the same chromosome loss make up one viable cytogenetic abnormality. But if you were to follow up this case, then the presence of only one abnormal cell was considered to indicate the same clonal abnormalities at previously detected. And by conventional cytogenetics, what do we achieve? We achieve numerical abnormalities. In the setting of aplastic anemia, you can have a trisomy 8, monosomy 7, deletion 5q, trisomy 6, trisomy 14, and deletion 13q. Of this list, which occurs in various kinds of aplastic anemias, or it may be seen that there is a overlap between MDS defining cytogenetic abnormalities such as monosomy 7, poor prognosis, deletion 5q, and deletion 13q. Deletion 13q is supposed to give a favorable outcome if it is present in aplastic anemia, not so much in hypoplastic MDS. Single nucleotide polymorphism karyotyping. This is metaphase independent detection of copy number abnormalities. It reveals more abnormalities than your conventional karyotyping. Small cryptic lesions and what is called uniparental disomy, UPD, have been discovered, and the most commonly observed is the 6p UPDs, which are seen in aplastic anemia. Now again, what is the relevance? This is a repetition. Trisomy is maybe transient and may be favorable, but monosomy 7 is always going to have a poor prognosis. I already told you that deletion of 13q are better related if it is a case of aplastic anemia rather than hypocellular MDS. Somatic mutations. Now that we have NGS based mutation studies, these somatic mutations are more reliable and sensitive, and their frequency has been this is a relatively newer technique in terms of conventional cytogenetics. So 5.3 to 72, the range is actually too much, and I don't know whether it is viable, but 2 types of genetic alterations have been seen. The highly specific for aplastic anemia is of course PIGA, BOCR and BOCRL1 mutations, and I told you 6p uniparental disomy. Mutations are commonly seen in MDS AML, example monosomy 7, DNMT MT3A and ASXL1, which are also seen in MDS AML, can be found in cases of aplastic anemia. So that brings me almost to the end of the lecture. I have tried to introduce the topic and haven't actually tried to explain each and every entity in great detail, but I wish you to go to at least this is my carry home message. Mandatory tests. Please, the checklist. Have you done a full blood count, reticulocyte count, peripheral blood smear, liver function test, and of course I can read it out. Pearl staining and bone marrow trephine whenever needed, 34 and 117, flow cytometry for PNH clones, auto antibody, anti-nuclear, anti-DNA. For HLH, of course, fibrinogen and serum ferritin, stool pancreatic elastase, serum pancreatic lipase, Schwarzman-Diamond syndrome, serum bilirubin, LDH for any hemolysis, chest x-rays, abnormal ultrasound and echocardiography for liver, spleen, lymph node and cardiac involvement. Now, suppose what are the these are the mandatory tests which we would do. Please, anytime, whenever you encounter a patient, it would be worthwhile to investigate it like this, along with your colleague in the clinical site. If there is a suspicion of a chromosomal Fanconi's anemia, chromosomal fragility test by mitomycin or diepoxybutene is a gold standard. In Fanconi's anemia, TERC mutation analysis for hidden forms of DKC are being done. Otherwise, also for those who have acquired abnormalities, or people who do not respond to immunosuppressive therapy, a TERT mutation analysis may be done for an acquired telomere fish. Telomere length is done by flow fish. I do not have any personal knowledge of the method. And lastly, of course, I have put my case forward for next gen sequencing and your single nucleotide polymorphism. With that, I come to the end of the lecture.
Thank you so much, ma'am.
Anybody has any query can...
There are a lot of questions and comments on the chat box. Would you like to read it yourself, or you want me to read it for you?
I don't see it actually. How can it be read out? I can't. Okay, let's see. Yeah, allogenic bone marrow. Dr. Pranab Kumar Bhattacharya has made a. Is it a comment, sir? Can we ask him to unmute his? Sir, can you please?
Yes, some are comments and some are questions.
Yeah. You are correct. Allogenic bone marrow transplant for HLA matched is a treatment of choice for patients under 50 years. Actually, I am really not the right person to be, addressing the treatment part, and would like your guidance in this. And can hematological relapse of what? Of aplastic anemia? We don't usually, and clonal evolution.
After that,
I'm sorry, it's voice is breaking.
Breaking, yeah.
Dr. Pranab, you can go ahead and just discuss it out. Your voice is okay. Go ahead, please.
Can hematological relapse and clonal evolution of pre-malignant clone can be evaluated by what method?
Okay.
Hematological. I don't know what you want to know, in the sense that you are asking that can hematological relapse in aplastic anemia and a clonal evolution.
Yeah.
Okay.
Yeah.
Yeah, it can be, because at the present moment, suppose it's a PNH clone. The PNH clone is not putting you, is not causing the relapse as such. It may cause, in fact, a PNH clone may give you advantage. The problem with the PNH clone is that it may cause hemolysis and thrombosis at the same time, and in the setting of aplastic anemia may be a problem. You are offering immunosuppressive therapy. The patients who do not respond to immunosuppressive therapy, mostly at the present moment, the situation, I can be corrected by any clinical hematologist who is here, that is being offered immunosuppressive therapy, and the patient is waiting for allogenic bone marrow transplant. So in case it is not available and immunosuppressive therapy is to be continued, if there is a PNH clone, it can have a disastrous problem. I don't know if this answers your question.
Actually, I have lost the connection. Can you hear me?
I can hear you, but I wonder if you...
We can hear you perfectly, and I think Dr. Basu has addressed the question absolutely appropriately. Please go to the next one, please.
The next one is about alemutuzumab. I will not be able to tell you.
Yeah, treatment protocols will not be appropriate for at this point. We are not handling, nobody is treating patients here, sir. We are only diagnosing. So please keep your comment to diagnosis.
How much can TERC and TERT predict the outcome of severe aplastic anemia? Actually, if you are suspecting a telomeropathy and you do not get a short telomere, or you do not get, say, the patient is not that of DKC1, it does have a role. But TERT is done initially and TERC is done later, when you do not get a TERT abnormality. There are so many more. I don't know if my presentation is visible. There are so many more which are there, and it is possible to do all this because of the fact that we have the backbone of flow with your FISH. All TERC and TERT are done by either FISH or by sequencing. Now, most patients, your last question is that most patients with aplastic anemia have cytotrisomy and monosomy found associated. Yes, this is an ongoing study actually, that monosomy 7 is seen in aplastic anemia and in AML. There is a significant overlap. That is why we are having this, we are facing this problem. That is why we are looking more closely at our marrows, and we are looking, we are going on to see, is there a somatic mutation which could be associated with aplastic anemia but not with your hypoplastic MDS. Trisomies are actually not being implicated. Means trisomies do not make a difference. But what does make a difference is deletion 13q. In the setting of aplastic anemia, it's a good thing to have, but not so much. It's one of the WHO criteria, no, 13q. So for a hypoplastic MDS, so actually on ground it must be hugely difficult to find out whether we are dealing with, in the absence of congenital anomalies, it would be very difficult to find out, is this a hypoplastic MDS or is this a severe aplastic anemia. We can only, again, I would like to refer to my checklist, the checklist that I had given, that in that, I don't know where my presentation is. I am not able to go to my presentation.
Just go to the PowerPoint below. And
I cannot see because
it will come.
Yeah.
No, I am out of that.
Oh, you are out of that, is it?
Acha. Okay.
Yeah.
That is why
we can hear you.
Yeah. Oh, yeah, we can hear you. Okay, then I'll minimize it. Oh shit! I don't.
It doesn't matter, ma'am. Please go ahead. I'll control it from here. Don't worry.
Yeah,
don't worry
yeah.
about it.
Achha,
Don't worry.
okay. Have I?
You want to share your presentation?
I would
just go to the taskbar and press that PowerPoint. Just go to the taskbar below and press that PowerPoint.
Is it required? I don't think.
No, it's not required. No, it's not required. Please go ahead.
And cytotoxic T cells and inhibitory cytokines, interferon and gamma interferon and two are main causes and result in the death of the stem cells. That is one of the things which is happening. That is not the only thing happening. Of course, I showed you that T8 cells. There's a problem with the Treg, T4 helper cells.
Actually, the stem cells are being dead. So stem cells to kill the stem cell. These cytotoxic T cells are going against the stem cells.
No, it's not a question of killing or not killing. Two things are happening. One thing is that it's like the easiest example is that you are comfortable, but your like the quantity is not increasing, but you are comfortable. Means the niche is, your micro environment is good, your bony environment is good, everything is good, and you are only taking cytotoxic insults, so that is how your numbers are decreasing. On the other hand, there is another very big arm here, where what is happening is the apoptotic pathway through these interferons and cytokines and T8 cells is getting, because of the fact that there is not only a quantitative loss, there is a qualitative loss also. Means because of the apoptosis and the hostile microenvironment and certain genetic factors, this is an interplay of everything that is causing the aplastic anemia. It's not only the cytotoxic T cells which are finishing off the, but yes, they do have a very, very important role.
Basically, it's a multifactorial activity.
Yeah, yeah. In my presentation,
we could understand that very clearly.
Yeah.
My point I would like to make one point here is with the changing advancement in molecular technology, every time a new genetic aspects are coming into front, and maybe like in other areas, like you can see in brain tumors and in lymphomas, where the entire classification is now becoming molecular. Even in aplastic anemia, a lot of stress on molecular activities is now being placed on. Any more questions, sir?
No, that's okay.
Right. So can I make a closing comment here?
Yeah.
Can I have one word in?
Yes, please, ma'am. The stage is all yours. Anytime.
Thank you so much. It's been a good experience. I hope there are some PG students around, and thank you once again. It's really a good experience.
My pleasure, always the pleasure is ours. It was a very wonderful presentation. We had a lot of people up here as well as on YouTube. And at the outset, let me thank ma'am for consenting to be on this platform. An excellent presentation on aplastic anemia, something which the PG students would like to go back and see. As you must be aware that this platform has a separate methodology of functioning, whereupon we have this recorded versions available for future convenient viewing, and that is where the maximum hits are. So most of the people go back and see it again and again, and we get multitudes of, you can say, feedbacks on all that. There are sometimes questions which come, and then we forward it to the speaker to address those questions. And we also have a drive, Google Drive, whereupon we are uploading all the PDF of all the presentations. So we would request you to share the PDF of your presentation. We will upload it in the drive so that people across the globe can access that and learn from that. We can't have Dr. Atushi Basu always here, take out time from such a busy schedule and teach us. So this will be there as a memorial lecture for everybody to learn and learn from. And as my closing comments, I would say, ma'am, an excellent presentation, a very detailed presentation, and I thank you for taking so much of time, and you have really worked hard in formulating this, compiling this presentation. It can be very clearly seen. Every aspect of aplastic anemia from the basics to the molecular has been covered. I think there's nothing much left into it. Rather, I would say there's nothing left into it. Thank you so much. and we would definitely disturb you in maybe 2 months down the line for something more in this, maybe on another topic. Thank you for everybody for joining in here. Please, thank you so much. Please share, ma'am, the PDF, and we will pass it on to you.
Okay, thank you.
Right, thank you. God bless you. Thank you. Good night, everybody. Thank you for joining. Bye-bye.